Hello, everyone, and welcome to the In Focus podcast. My name is Andrew Pucker. I'm the Senior Director of Clinical Medical Sciences here at Lexitas. And today I'm joined with our expert, Dr. Lanita Scott, who will be with us discussing an exciting paper. Lanita, could you please tell us about yourself and what you do at Lexitas?
Hi, so I'm Dr. Lanita Scott, and I'm Senior Vice President of Medical and Clinical Sciences at Lexitas, and I'm involved in a lot of the medical monitoring and the reading center activities that go on at Lexitas.
Awesome. Well, thanks for being here today. Today we're going to be discussing an ancillary study out of the Philly study. Could you give us a little background on what happened in this trial?
Yeah, so this is a really interesting paper and trial. I think, as everyone knows, geographic atrophy is one of the leading causes of blindness in industrialized countries. And so, really preventing loss in this disease is really critical to long-term eye care for many people. And with the study, they looked at pegcetacoplan. I hope I got that right. I think you can Google how to pronounce it if I butchered the name at all. But it plays a role in the complement system in AMD pathogenesis. And pegcetacoplan is a C3, a complement C3 inhibitor, and it slows progression of geographic atrophy. And as Andrew said, it was shown in the phase 2 trial Philly and also in the phase 3 trials. So this study really looked at looking at additional foci outside of the primary lesion to see if they could slow the progression and whether the monthly dosing or every other monthly dosing slowed this down or not.
So we all know that the RPE is very important for retinal health, but what other layers did they look at in this study, and why might they be important for understanding if the product's working?
Yeah, so degeneration is really localized thinning of that outer nuclear layer at the so-called junctional zone, and this is that 500 micron band surrounding geographic atrophy. And even at Lexitas in our reading center, a lot of studies were involved, and we really looked closely at that ONL layer as well. So they really looked closely at that to see how the drug impacted changes.
So they have this cool method. What did they find with it?
So what they found is that looking at, I think, almost 200, just short of 200 patients, the they looked to see in these bands if they had reduced degree of progressive thinning at the level of the ONL compared to sham. And what they found is that in both arms, whether patients were treated monthly or every other month, that the degree of thinning was lessened with the pegcetacoplan treated groups. So, this was, really impactful.
So one thing I thought was interesting that is that they did two different dosing regimens in this study. One was every month, I believe, and one was every other month. Did they find a difference from this?
Yeah, the difference between monthly and every other month was very minimal. I don't have the numbers. I think it was almost 2% or so, very, very small difference compared to the untreated group. And they even found that treatment stopped at month 12, and they still had a persistent effect from month 12 to 18 in both of those groups, whether it was monthly or every other month. So that was great to see as well.
Well, I know how good I'm at taking my medication, so if I can get away with every other month, I'm definitely going to do that.
Absolutely. And as we learn with a lot of the anti-VEGF studies, treat and extend, and the retina specialists will try many different regimens to lower that impact.
I know this is more of an analysis paper, but are there any take-home points that you would want our clinicians to take to clinic or people to take to their research lab?
Yeah, so I think that the real take-home message is that treating with these types of drugs will prevent progression. But I think what we should probably look at is to do additional studies where we get patients earlier in disease, because of course, if we can treat the progression, that's great. But if we can treat it from even getting to the point where they get enrolled in the studies, I think ultimately patient outcomes will be better, and visual health will be better in the long term.
I totally agree. If you can get someone before they've lost most of their vision, that's really the way to go. So
Yeah,
hopefully we can get more and more treatments in the pipeline that can help people, even when they're like 2025, we want to keep them seeing for their whole life, right?
absolutely. Yeah.
So with that, I'd like to thank Dr. Scott for being here. I'd like to thank you all for tuning in to another installment of the In Focus podcast. Thank you.
Thank you, Andrew.